Morning everyone, today we'll discuss the maternal anatomy from Williams textbooks. The chapter 2 will basically discuss the anterior abdominal wall anatomy. So anterior abdominal wall, there will be a skin and subcutaneous layer, and the fossa. The anterior abdominal wall confirm the abdominal viscera. That basically what is the point you have to remember from this paragraph. This is the basically you have to remember the Langer's line orientation. You can see the Langer line orientation describe the orientation of the dermal fiber within skin. Actually this Langer's line, they lie transversely. As a result, when we have a two incision we are giving in the abdominal wall, that is your vertical incision and your low transverse incision. If you give a vertical incision, that will cause, as a result of vertical incision, that will cause sustained greater lateral tension, because it will cause and that will lead to a wider scar. Okay, and the second things, if you compare with your vertical incision compared with the low transverse incision, if usually you are giving the peninsula incision, that will follow the Langer's line. Because it is follow the Langer's line, that will cause less strength to the wound, and that will cause superior cosmetic results. Okay, so basically from this paragraph of this Williams textbook, skin, subcutaneous layers, fossa, you have to remember the Langer's line. Okay, then second thing is the after the skin, you will get to the subcutaneous layer. In the subcutaneous layer there will be two layer, that is a superficial and deep layer. The superficial is your fatty layer, that is a fossa compares, and the second is the deep membranous layer, that's a fossa scarpa. Okay, these are the two. Caesarean section, you can remember Caesarean section and FD. Caesarean C is the Camper fossa and S is the Scarpa fossa. C is the fatty layer, D is the first layer is the fatty, and the second is the membranous layer, is the deep membranous layer. Okay. Then how this camper fossa is continue, this camper fossa continue onto the perineum to provide fatty substance to the mons pubis. Now the camper fossa continue downward to the perineum to the mons pubis and the labia majora, then blend with the fat of the ischial fossa. Same thing, the scarpa fossa continue inferiority unto the perineum as continuous Colles fossa. Okay, so very important, these are the continuously. Scarpa continue as the fat of the ischial fossa, camper fossa continue as your Camper fossa is continuous fat of the ischial fossa and the mons pubis and the labia majora, and Scarpa fossa, the lower part, inferiorly it continues Colles fossa. Okay, then after this subcutaneous layer, you know everybody has anterior abdominal muscles, that is beneath are the midline rectus abdominal muscles, and the pyramidal muscles are the two basic muscle as well the all three external oblique, internal oblique, and the transverse abdominal muscles. Actually this fibrous appendages of the all three lateral muscles from the primary fascia of the anterior abdominal wall, that is the rectus sheath. Okay, they are fused in the midline at the linea alba, which normally you can see the measurement is less than 50 mm below the and abdominally, if you get a abdominal reflex diastasis, then it will cause a, if cutoff is 15 mm, the 15 mm between this linea alba distance, this is the 15 mm. So if you get more than 15 mm, then it is called diastasis rectus, or the chances of ventral hernia will occur. Okay, so you can see this is the anterior abdominal wall. There is a various structures: rectus abdominal muscles, external oblique, internal oblique, transverse abdominal muscle, lateral cutaneous knob, anterior rectus sheath, posterior rectus sheath, and the arcuate line. Very important. The arcuate line is the upper one third of midline vertical incision. This is the important point, landmark. Above this arcuate line, you will get two layer. Above this arcuate line, you will get a two layer of rectus sheath, that is the anterior and the posterior layer. Below this arcuate line, you will get a single layer of rectus sheath, only the ventral layer, that is the anterior layer. And this is the iliohypogastric, that is originated ilioinguinal, and these are things you will discuss each and every part. Okay, the arcuate line, basically I told the three aponeurosis also invest the rectus abdominis muscle as the rectus sheath. The construction of this sheath very above and below the arcuate line. Actually above the arcuate line there will be two layers, and the below the arcuate line there will be a one layer, anterior posterior, here the anterior only. Okay, basically when you are giving midline or vertical incisions, the upper one third part, you will see this transition very easily. Okay, the pair small triangular pyramid muscles originate from pubic crest. Very important, origin is pubic crest and inside into the linea alba. So then after this skin, subcutaneous layer, the muscle layer, you will go to the transversal fossa. This is the thin fibrous tissue, it will cover the transverse muscles. And next is the umbilical, there will be a remnant of the abdominal wall. There will be several peritoneal remnant, that is a median umbilical ligament. There are three ligaments, that is median, medial, and lateral. The median umbilical ligament is the remnant of the urachus. There is a fibrous connections between the bladder and your apex of the umbilicus. Then medial is the umbilical ligament, it's the obliterated fetal umbilical artery, and the lateral umbilical artery is the part of inferior epigastric vessel. So these are the things from this paragraph you should to remember. Then blood supply and the lymphatic. Basically, the first you will discuss the blood. You will know the all the layer, and then the applied anatomy. You will see the from the blood supply and the lymphatics. The blood supply here you will see get so many applied anatomy. The superficial from blood. If you see the blood supply, there are two artery. One is your external iliac artery, and in your external iliac and the femoral artery. The first superficial femoral artery branch is the three branches that will supply the skin and subcutaneous layer of your anterior abdominal wall and mons pubis, that is superficial, three superficial epigastric, superficial circumflex iliac, and superficial external pudendal. In this image you can see these three artery. This is the superficial circumflex iliac, superficial epigastric artery, and this is circumflex iliac. It is rounded. This pudendal artery, external pudendal artery. Okay, these three arteries supply the skin and the subcutaneous layer of the mons pubis and the anterior abdominal wall. Okay, this is the subcutaneous layer, anterior abdominal mons pubis. The superficial epigastric artery. Actually, this you can see in this image how the superficial epigastric artery run diagonally. You can see this is diagonally running. Okay, how it is running. The superficial epigastric artery is running diagonally towards the, you can see this is diagonally running toward the umbilicus. So basically during your slow transverse incision, the first on the skin incisions, this artery can injure. So very careful during your surgical sections, cesarean sections. Okay, so it is run diagonally. I told run diagonally towards the umbilicus. It lie above. This is the applied anatomy. Here is the superficial epigastric artery can be injured during your cesarean section because it lie above the fossa scarpa, that is your membranous layer. So during the cutting the layer by layer during the cesarean section, you should occlude the artery. Better to prefer to occlude the vessels so that it will prevent bleeding. So basically this is the applied anatomy. You have to very careful during this incisions. Superficial epigastric vessels surgically important. It will course diagonally from their origins toward the umbilicus with low transverse skin incision. This vessel can easily identified at a depth halfway between the skin and the anterior rectus sheath. They lie above the scarpa fossa, several centimeters from the midline. Ideally, these vessels should be identified and surgically occlude. So this is the basic anatomy. This is the applied anatomy. Then you should go to the lymphatic. The lymphatic usually runs applied and caudal on the lower abdomen. Most of the channel it should be in the dormis, and the smaller density is found between the two layer of the abdominal fascia, that is camper and scarpa fossa. More deeply you will get a inferior epigastric artery. You can see in the deeply there will be an inferior epigastric artery. Next thing you can see there will be a superficial epigastric. There is a superficial blood supply over the skin subcutaneous layer, and the deep supply to the muscle. That is the very important artery is the inferior epigastric artery. You see how nicely it is running above the rectus. This is the inferior epigastric artery. This one is your inferior epigastric artery. Okay, so inferior epigastric running above the rectus muscle. So during basically this is the inferior epigastric artery. You have to more careful during your muscle cutting incision. In the previous section only, previous section said there is much more adhesion you can get. So in that case, when you are cutting the muscle to get adequate space, that case you should be more careful during cutting this inferior during cutting muscle cutting. So more deeply the bilateral inferior epigastric artery veins are respectively branches of very important. The superficial epigastric artery is a branch of external iliac, but inferior epigastric artery is a branch for external iliac vessel, and it is supplied the anterior abdominal muscles, nerves, fascia. The anatomy, surgical anatomy is the inferior epigastric artery. Initially it is goes laterally, then it is goes posterior to the rectus abdominal muscles. So which there is a deep system in lymphatics follow this artery. Clinically, when you go for a maillard muscles incision, very important statement. Maillard muscle incision used for cesarean delivery, the inferior epigastric vessels may be lacerated. So during muscle transaction, actually normally in the primary section, okay, in your primary cesarean section, you will not doing muscle cutting. But if a previous cesarean section, usually you should go for a muscle cutting incision, that is your maillard incisions. So there will be chances of injury. So previously you should beforehand you should identify the inferior epigastric artery. It is lie initially it is run laterally, then it is lie run posterior to the rectus abdominal muscles. So you have to more careful. You have to identify and surgically occlude the preferably. Preferably you should occlude vessel before going to, and very rarely there will be ruptures and spontaneously or traumatically during pregnancy to create a rectus hematoma in pregnancy. On each side the lower abdominal there another thing is very important, the hernia part. Here the Hasselback's triangle is come into account. You everybody is know there will be Hasselback triangle, their boundary is the midline, there will be a medial border of the lateral border of the rectus abdominal muscles, and the laterally there is the inferior gastric artery, and the lower border is the inguinal ligament. If any content passing through this Hasselback's triangle, that is called as the direct inguinal hernia. If it is go lateral to this, then the indirect inguinal hernia it should be called. Okay. Then the knob supply of the anterabdominal, the anterabdominal wall is innervated by the intercostal knob, that is T7 to T11, and the four knobs, that is intercostal knob, subcostal knobs, iliohypogastric, ilioinguinal knob. Okay, the first two is the neurovascular bundle of the anterabdominal muscle plane, that is the transabdominal plane block when you are giving the anesthesis between transabdominal muscle and interoblique muscles. Basically in this plane you will get intercostal knob and the subcostal knob. So post cesarean analgesia blockade can be given. The applied anatomy is the post cesarean analgesia blockade is given between the neurovascular bundle of this anterior abdominal wall between this internal oblique and transabdominal muscles. Actually this intercostal and subcostal knobs is the origin from the, you can see the origin from the anterior ramus, then drawn laterally into, they'll give a branch to the anterior lateral cutaneous branch of anterior abdominal wall, then go forward, then give a anterior cutaneous knob branch to the anterior abdominal wall. So basically the tableau given here between the two muscle layer very important, because during gynec surgery or any post cesarean they can give transabdominal plane block that can use for the blockation. Okay. So next is the near rectus abdominal muscle. The next knob is your near the rectus abdominal muscle, the lateral border. The anterior branches of the intercostal knob superficially the sectus sheath. These are the knobs. You can see this is the very near to the your incisions. So these two knobs, the anterior cutaneous knobs, because they are running lateral border of the rectus abdominal muscles and pierce the posterior sheath and rectus muscle, then anterior sheath to reach the skin. The knob very chances to this nerve injury during your phalangeal incision, that's suprapubic transverse skin incision. Next knob is your iliohypogastric. The applied anatomy is your chances of injury very careful, so that will not that much problem. Iliohypogastric knob, that is a L1 anterior lateral border, it is passed through lateral border muscle, then from posteriorly it is go to the quadratus lumbrium muscles, retroperitoneally it is sometime, then you come to iliac crest. Then very important, the edge lies 2 to 3 centimeter. The iliohypogastric knob lies 2 to 3 centimeter medial to the anterior superiliac spine, and the pierces the superficial layer. So what is the applied anatomy of ilioinguinal knob? 2 to 3 centimeter medial to the anterior superiliac spine. So basically when you give a low transverse incision, this knob can supply mons pubis, upper labia major, upper thigh. The chances of injury can be severe during low transverse incision or interrupt during closer, especially if incision extends beyond the lateral border rectus. If you go beyond the lateral border rectus muscle, then that chances of injury is high. And another thing, during the port incision, so you go you should be laterally to the anterior 2 to 3 centimeter middle to anterior. So in your laparoscopy port incision also you should be very careful, don't injure the ilioinguinal in your hypogastric knob. It has a, if you caught this wrongly, then you will get a loss of sensation above the pubic symphysis, mons pubis, and upper labia majora skin and median thigh. Okay, so basically the ilioinguinal nerve is the perforate through the, it is supply the suprapubic area, and the iliohypogastric is supply the suprapubic area skin, and the ilioinguinal nerve skin supply the skins of mons pubis, upper labia majora, medial upper thigh. Okay, so these are the area. It is very important. If you caught, there is no motor loss, only the sensory part will gone. Very applied anatomy. And next thing is the dermatum. T10 is up to umbilicus. So basically normal vaginal delivery and labor pains you have to give blockade. If you give epidural analgesia, the level should be up to T10, or during vaginal birth up to T10 is very important, is done easily. But for a cesarean delivery or puerile sterilization technique, regional analgesia has to be extended till T4. So basically these are the key points from the Williams textbook of obstetric chapter 2. Very scriptly I told. Thank you. If you like, please subscribe. This is the Williams obstetric series. I'll discuss every chapters very daily basis. Please like and subscribe. Williams series. Okay, thank you.